Hi, thanks for joining me back here. I'm really delighted to now be joined by Associate Professor Thomas Kalincik. Thomas is a neurologist and statistician and actually really loves maths for fun. That's a fun fact about Thomas. Thomas is the head of the MS Centre at Melbourne Health, and he's also head of the core or the clinical outcomes research unit at the University of Melbourne. Thomas is a member of the MS Base Scientific Leadership Group, the chair of MS Base Data Quality Committee, and he has published over 50 papers, mainly in MS epidemiology, prognostics, treatment effectiveness, individualised therapy, and utility of volumetric MRI in MRI. One thing that captures Thomas is his deep care for solving people's problems living with MS, and also his brilliant mathematical brain. So he combines those two to be able to head up the very large service in Melbourne for the MS clinic there. But today we're talking, Thomas, about some of the barriers that people have to connections, and you're looking after lots of people with MS and providing care for them. Can you talk about how some of the barriers that people have to connecting with each other that MS itself brings about?
Thank you, Judy, for a very lovely and kind introduction, and thank you to MS Limited for hosting me today as part of this event and recognising the World MS Day. The barriers, there's a number of them. I feel I'm having a little bit of imposter syndrome here because I'm usually the person who may be talking to people about the barriers, but they are the people who experience the barriers. So please allow me a little bit of a license and sort of try to provide my reflection on the barriers and where I see them. So take that as a doctor's perspective and see how that corresponds to your own experience. And I think that is the important also angle for us to understand where the doctors, the healthcare providers and people living with MS and their carers come from, and perhaps this conversation may help us identify some of the gaps that we should be focusing on filling in the near future. So probably starting from the most obvious to me, the disease itself imposes a lot of barriers in everyday life for everyone living with MS and their carers and their loved and close and their colleagues and employers and the broader community surrounding. It's to be talking about networks of people. We're not talking about an individual person who's isolated in the society, of course. So the symptoms, there is a number of symptoms that the medicine or neurology has answers to, symptomatic therapies, and I guess that is not the purpose of our conversation today, to talk about those symptoms that we are good at dealing with, but perhaps what I would like to highlight are those symptoms of MS, presentations of MS that I find frustrating as someone who is trying to help people who turn to me with questions or asking for help with these symptoms. And I'm sure people living with MS would be in much better position to comment on how relevant these different symptoms are. So obviously what the world of research in MS Limited, MS Australia, MS Research Australia and the international MS research community is focusing on is dealing with progressive MS. And the progressive MS is defined as a type of disease that manifests with insidious, slowly deteriorating or slowly worsening symptoms that perhaps if one was to live with them for half an hour, there will be not a big deal. But imagine you live with a symptom that is subtle but always present for the entire life, and that's where it becomes really tricky, frustrating, in particular if your neurologist tells you that there's not much we can do about the symptom and the symptom is slightly getting worse. Where I can imagine the frustration really starts to creep in. So a very typical example of that would be fatigue. And we really do not have any answers to MS-related fatigue, and it's an incredibly common symptom. I would say well over half of people who I see in the clinics with MS mention fatigue in a certain form or shape. Sometimes it borders with so-called mental fog or brain fog, so there is a bit of a grey zone between cognitive changes, so deterioration in memory, in attention, typically in multiple sclerosis, and fatigue, and one can fuel the other. There are trials, there are studies that are underway looking into these symptoms, but so far we do not have any satisfactory answers as to how we can suppress these particular symptoms. The other symptom that I probably should highlight is pain, neuropathic pain. We have some solutions, we have some therapies for neuropathic pain, which is common in MS. But it's a long, as many people have experienced, it's a long run. And neuropathic pain as a symptom can be very resistant to therapy. Some people are lucky, and we find the right treatment to suppress the symptom for a period of time, but initially. But like MS is an evolving disease, and often 1 or 2 or 3 years down the track, the symptoms re-emerge, and we realize that what in the past used to be sufficient treatment for the symptom is no longer sufficient treatment for a symptom.
And you did, back to that fatigue and the brain fog and the pain as well too. They really are huge barriers for connection. We all experience them in our lives at times. You know, kids, busy work, we all experience that on and off. But living with that every day, that real fatigue, and certainly people in the clinic would be telling us, people living with MS, it's a huge barrier to them being able to connect with people as well too, and certainly a big area of. I'm glad that there's research going on to try and help people with that, and also we also have, we experience intermittent pain, and how much you just want to close the door and curl in a ball and say, I've got pain, please leave me alone. And do you think that people are talking about that enough in clinic? Has that changed in your time of being a neurologist, that we're starting to really understand that more and the impacts of that in clinic?
It certainly has. Over the last 10 years, I've been noticing a shift from a more doctor-driven model, where it's basically a question and answer session, to a more patient-driven model. Of course, that highly varies depending on the location, the site, the doctor that you're dealing with. But I think, and I'm happy to be corrected actually based on the personal experiences of people living with MS, but my impression has been that there is now a little bit more focus from the healthcare provider's point of view on the symptoms, even the symptoms that may be frustrating for the healthcare provider themselves, because we got to recognize that even the frustrating symptoms, they shouldn't stop us from talking about them, from validating them, and from looking for answers. And it's particularly important knowing the person who's sitting with me as a doctor in the room, if an opportunity arises, to potentially offer them something. A very good example is a randomized control trial of high-dose food supplements, high-dose vitamins, called Relief MS. It's based here in Australia, funded by NHMRC and MSRA. It focuses on testing a hypothesis of using food supplements or vitamins and other supplementary substances that are normally present already in our diet, but this time administering them at much higher doses than what we would normally ingest, and looking at how they interfere with the metabolism of damaged neurons, and whether they can improve the efficiency with which these neurons work, and potentially the clinical impact, hypothesized clinical impact of this intervention would be improvement or relief from some of the symptoms of MS-related fatigue. So here is an example, but for this example, it's important for a healthcare provider to monitor who are the people who would most likely benefit from this type of approach.
And I guess there's those frustrating symptoms that are really hard to deal with, but there's also ones that we have treatments for. So going back again to that sort of symptom management, what do you think are some of the main symptoms that people live with MS that there's really become much better options for to be able to treat?
Yes, I would say that there has been a lot done in the field of spasticity. Apart from the traditional pharmacotherapy for spasticity, and spasticity is a symptom that is fairly common, particularly as the damage to the motor pathways increases over time, the neurons in the spinal cord become disinhibited and they start firing at their own will. creating this the pattern of spasticity. So there is traditionally the pharmacotherapy that helps us somewhat ameliorate the effect of spasticity. But we have also, as neurologists, have realized that it is very important to approach spasticity from a multidisciplinary point of view. So now rehabilitation, medicine, physiotherapy, occupational therapy have become a standard part of the package. And to a certain extent, NDIS has stimulated that interaction, because NDIS provides people with a package that is almost predefined. Well, predefined. That needs a lot of tweaking, but societies like MS Limited have been doing a lot of tremendously helpful, I would say unique work in this space for people living with MS, helping them navigate this complex terrain of NDI support, where there is a lot at stake. There's a lot of work to go into that, but they can gain a potentially fantastic supportive package. So coming back to the question, the essential part is now that we have learned to approach something like spasticity from multidisciplinary point of view. The next frontier for us is to bring this care into one place, or into a limited number of places. You know, that people who live with MS, they know better than anyone else that in order to receive different parts of their care, they do their rounds. They go and see a physio here, and they see an OT there, they see their neurologist, they talk to MS nurse, they call MSL. We should be really striving at bringing all these different aspects, these elements of care, into centers, into one place where we can really focus on the person sitting there in the room with us. And rather than having them do their rounds, we should do that work for them.
I think what you're capturing there really nicely is that over time we've also, what we've learnt about MS and being an MS nurse for so long, I can see really clearly that we've learnt that it's more than just treatment, disease treatment with treatment. We've just changed things so radically, the way that we can support people living with MS. But it's about that concept of total well-being, and that you can have a disease which technically looks well treated, but it's not really capturing people's well-being and all of the well-being and all of the impacts that sort of create a whole concept. And that's certainly something that medicine, and particularly in MS, is really starting to broaden out their understanding. And it's great and really exciting to hear that research is really stepping into that space as well too. We're looking at food supplementation, people are looking at different ways, people are looking at how peer support can add value to that. I do want to go back to the treatments, because I think in COVID particularly, lots of people with MS were on a disease-modifying treatment and felt that really, and continues to be a barrier for connection. And how have you found that in clinic, and what sort of fears and vulnerabilities have you seen emerge, and how have you kind of helped people tackle those?
That is a very interesting thought, Jody. I'm glad that you're highlighting it, because as healthcare providers, we tend to view treatments as the pure solution. It's not only a solution, it's a barrier. It comes with a number of tags, number of safety precautions. People have to attend clinics to receive infusions, or people have to inject themselves, or remember to take a pill once or twice a day. These are all barriers, potentially, and particularly if we combine them with some of the symptoms that we have mentioned before, like spasticity in the upper limbs that limits fine motor skills. Someone may find it difficult to inject themselves if the fine motor skills are not 100%. And same thing applies to, say, memory issues. That could be potentially a significant barrier for someone who is meant to remember twice a day to take the medication and how they're taking it. So the treatments do come with a long list of potential barriers that clinicians we sometimes may forget about. And of course, then there is the safety follow-up, the requirements of administering these treatments that thread the fine line of tampering with the immune system in order to protect the brain and spinal cord, to administer them with caution and safely. The way we support this Well, I think that we still need to find a unified strategy to that, but I think we're blessed with working alongside people to whom this is in the epicenter of their focus. And you're one of them, Jodie. Is the specialist MS nurses who really help guide patients along this path and sort of talk to them about that fine detail of what a therapy for MS comes with. Often a clinician would run out of their time in the clinic to go through the fine detail. But I found the nurses to be very important part of that conversation to offer the kind and guiding hand in that particular scenario. And who's the person who the patient will call and ask, I'm having such and such symptom, I'm not sure whether that is MS related. It's not the neurologist, it's the nurse. And they want to hear the opinion of the nurse about what does this mean for how they're taking the treatment. Of course, then there is all the safety monitoring. And again, this is something that, in my experience, nurses are fantastic at guiding patients through.
I think what doesn't have visibility as well is or clear visibility is the amount of intensive amount of research that, particularly over the last 6 to 12 months, that's gone into really deeply exploring for instance, vaccinations and MS and what they're going to mean for people. And so that perhaps doesn't have visibility in terms of the work that's going on to break down that barrier so that people understand better. And that constant, if you go to one of the conferences, you see that people are there's a lot of research that's going into that work to make it, to better understand it so that people can break down those barriers with the treatments, to understand the safety, the implications. That was really highlighted in COVID, but it's clearly something that's been going on a long time before that. So that's really exciting to see. We did touch on the concept of wellbeing and how that's changed in medicine. I know MS at Melbourne Health, the MS clinic that you head up, is starting to really look at that. Can you tell us a little bit about where that's going and how you're sort of trying to incorporate those concepts into everyday clinical practice?
Yeah, I think I have touched upon some of the barriers, and being very much aware of those barriers, those being the fact that, as I said, a lot of that responsibility, a lot of the work is left to the people with MS and their carers and families. We feel that there is a certain place for the healthcare providers to assume some of those responsibilities or help people by taking on, or maybe assume the responsibility is not the right term, but perhaps help structure the care better for those who are on the receiving end of the care. And because this is complex, the care is complex as well, of course. So what we envision is that perhaps let me first provide a little bit of insight into where we are in Australia, and I'm speaking to this from the point of view of someone who's trained in a different system. So in Australia, the public healthcare system basically is centred around shared resources. So people go to public hospitals if they receive their care in public centres, and it's usually the mode of care for specialised care in Australia. So they come into public hospitals and they're seen in shared public clinics. The pathway to contact their service is usually not that straightforward. Usually there will be a telephone link to call, a telephone line to call, and then they will be contacted back. Then there is a new shared infusion centre, for example, shared radiological resources. What we are always deficient in the public healthcare system are the supporting services, neuropsychology, psychology, rehabilitation, occupational therapy, social work. There are very deficient resources in our care. As I said, in order to access some of these resources, patients do, or people with MS and their families do their rounds around the system. So typically they're seen in the clinic, and the clinician thinks that there is a reason for a continence clinic review. There goes the referral to continence clinic. After 6 months, when there is a capacity, the person gets seen in the continence clinic. But of course, that means that the person has to put up with a symptom that is potentially treatable for 6 months before that symptom is being attended to.
And 1,000 barriers.
Correct.
Who said, she said, Corset, as we know very well, that navigation of barriers in itself, but yeah.
Correct. And because the public hospitals are generic environments, for that information to flow through that environment to be trackable, it's not that easy. So it does happen that information can fall through the cracks, and an appointment can be lost or can be missed, or if a person with MS misses their appointment, it doesn't get rebooked. And it's very important that the people who are on the receiving end of these services keep track of how this information is tracking. I think it's our responsibility to optimize that system. So where I trained in Czech Republic, the centre at Charles University looks after about 4,000 people with MS and their families, and it's approximately similar size to the centre or to the MS service at Melbourne Health, where our capacity is about 1/3 of the one in Prague. So where does this difference come from? Is the specialised nature of the centre that makes the whole difference. So if there are dedicated resources, and it starts from simple things such as space. If there is a dedicated space, there is always an MS space, then there are clinics running 5 days a week. And then in those clinics, there are specialists who come from different areas. They come from neurology, from urology or continence medicine, from physiotherapy, rehabilitation medicine, occupational therapists, social workers, administrative support, all dedicated for providing organising care for people living with multiple sclerosis. Then it has two important downstream effects. One, it creates a sense of ownership. It becomes a bit of a community, because then there is this epicenter of activity, and if someone needs to access their nurse and wants to talk to them about their next appointment or ask a simple question, they can just swing by if they, on the way, if they happen to be passing by, they swing by and ask a question, or they know where to call, and they receive the information almost real time. And two, it helps the organisers of the clinical care centre the activity around the patient. So if we know that there is, for example, there is a person coming in who in the past voiced their concern about their deteriorating memory, we can make sure that we book them in the clinic at the time when there is a neuropsychologist going to be present. And they can have a back-to-back appointment with a neurologist and neuropsychologist. And after that, sit down with the nurse and talk about, try to bring all the information together and come up with a plan that is meaningful and potentially with an impact on the quality of their life. So I believe that in Australia we should be moving now from the shared, fairly generic model of care. We're trying to fit specialist care into generic healthcare provision services, and we should be really moving into the area of specialised targeted healthcare provision.
I've noticed that it's really exciting to hear that, because it does open up so much opportunity for enhancing wellbeing, for considering all aspects of the people. And I do know that certainly in other areas of health, for instance, the heart, in heart conditions, that Monash is building an enormous heart hospital where they're capturing the whole flow, right from research, I think the research, and building right up to clinical care, all in the one place in the heart hospital. And I think that direction's really exciting and will create a whole lot of future benefits for people, and hopefully not too far in the future. But just before I wind up, I guess the ultimate barrier of MS is MS in itself. And so I know you're doing an enormous amounts of research, but what do you think are what are the parts of research that are really exciting you at the moment?
I like to look at what we already got. And if we look 25 years back, there has been an incredible amount of work that has already been done. We have learned a lot about this disease. The question is, how good are we at getting the information from the bench, from the lab, from clinical trials into clinical practice? And it sounds like perhaps a fairly trivial question. I mean, if one would think, if there is something good that's found at the bench, why shouldn't we be using that information in clinical practice? But there is always this deterioration of that information pathway between the different points in research. So what I'm passionate about, and there are a number of research initiatives that are looking into this, such as the MS-based collaboration, a number of great research centres around the city, the Monash, the University of Melbourne, Eastern Health, Austin, who are part of these research, who are basically research hubs on their own, where we are learning about and working together and learning about how we utilise for example, how we target a specific treatment to a certain patient or person living with MS with a certain set of symptoms and in a certain life circumstance. At the moment, or until recently, a lot of that decision-making relied on the clinician's experience. We want to move beyond that. We want to use evidence. We want to use the cumulative experience of over 76,000 patients from around the world. I'm talking about the MS-based cohort, and how they fared had they made different treatment decisions in different clinical scenarios. This is the clinical aspect of it. The biological aspect of targeting therapy is what we are passionate about is developing new biomarkers of potential future treatment response. And there are biomarkers that can be, candidate biomarkers that can be found in blood, that can be found on brain MRIs, or even things such as a response to previous exposure to certain therapies informs us as to how likely a person is going to respond to a different type of therapy in the future. Those signals are there. We just need to learn how to decipher them. And that's where the advanced statistics, where the mathematics comes into picture and helps us work with the big data. The third area that is currently undergoing a large development is the way we capture this information. And there are colleagues, for example, at Monash who are passionate about developing resources to record information directly from people living with MS, providing these resources to people with MS, such as apps, such as interfaces where they can capture for themselves the cause of their disease that facilitates the communication of this information to their healthcare providers, but also gives them a easily accessible and visible, almost visible schematic of their journey with MS and whether objectively things are or are not getting worse for them.
Well, you've wrapped it up with an incredibly optimistic and hopeful view of all the different areas that research is headed towards. And you're right, we've come so far in knowing so much, and even that step towards looking at how we deliver healthcare and how we and the concept of well-being and total people and how the person-centeredness, and that's just research is wrapping itself around that. So thank you for that time and giving us that really optimistic view of the future. You've got a lot of work to do, so I need to send you on your way and get crack-a-lacking. But thank you, Thomas, for that, and yeah, we really appreciate your time.
Well, thank you, Jodie, and thank you to MSL. It was a great opportunity.
Okay, thanks.